Hi everyone, good evening or good morning or good afternoon depending on where you are joining us from. Thank you so much for taking the time to join this live webinar. So the topic of the webinar tonight is on rectovaginal fistula. So this is something that we have heard from the group many times that we'd like a sort of devoted webinar to. So tonight we have the opportunity, and we have Phil Tozer, who many of you are very familiar with by now, and one of his colleagues, Charlene, as well, joining us. So both Phil and Charlene are experts in this area, so we're really, really grateful to have them joining us tonight. I don't want to take up too much of their time because we will hear as much as possible from them, but just a few housekeeping things for how this is going to go. So we're going to have a couple of presentations first, and then we'll move on to address some of the questions that have already come in prior to this evening. And then at the end, if there's time, we'll deal with some of the questions that are coming in through the chat. So if you do have a question, feel free to put it in the chat, and we'll get that across to Phil and Charlene through the webinar. If you do want your name to be attached to it, you'll have to write your name at the end, because everyone's name is anonymous and just comes up as guest. Of course, you don't have to write your name on it. So we'll try and get through as many of those questions as possible, but obviously we are limited to time, so we'll do as much as we can, but this doesn't have to be, of course, the last conversation about rectovaginal fistula. I think that's it. The other thing just to say is probably coming up towards the end of the webinar, I'll put a little announcement in the chat to say that we're closing it for any more questions. And also, don't feel free to not limit the chat to questions. If you have any positive feedback, or you want to feedback anything positive about the night to Phil and Charlene, I'm sure they would really appreciate it. So they're both based in St Mark's in London, and I'm sure that we're going to learn a lot from them tonight. So without further ado, I'm going to pass over to Charlene, who's going to lead us through a presentation to begin with. So thank you very much, and I hope that this is a really useful and informative time for everyone here. Bye.
Hello, can you all hear me? Hello, so good evening to those who are from the UK. Let's just get this on. My name is Charlene. I'm a research fellow, and I'm also a training surgeon, and my boss is Phil. And I've decided to dedicate 3 years of my life to really understanding what a rectovaginal fistula is, and more importantly, to understand how it affects a woman, how it affects her life, and how treatment affects her life along the way. So what exactly is a rectovaginal fistula? So this picture is of some of the organs in a female pelvis. So this is the uterus here, you have the vagina here, and this is the rectum where stool passes, and this is the anal canal, and this is surrounded by a muscular sphincter which controls continence. And there's a very thin sheet which separates the vagina and the rectum, and when there is communication between this, what happens is you get a very short tunnel, and what happens is that you get content such as mucus or discharge, and particularly in those who have problems of loose stool will complain of feculent or stool coming through the vagina. And these tracts tend to be quite short, communicating between the rectum and the vagina. You can, of course, get tracts communicating from the anus down to the vagina, and often these are quite long tracts. So what sort of symptoms do these patients complain of? So as I've mentioned before, you can of course get flatus and stool coming through the vagina, and some women complain of that they have foul smelling discharge, feeling quite dirty and unhygienic all the time, and they're very conscious of this, and this can affect their self-esteem because they're worried that people could smell them, or they might have staining in their clothes. It can also cause recurrent urinary tract infections. And there's the topic of painful sex, and I think sex is a subject in itself. Particularly for women, sex, or in any relationship, sex is a spontaneous thing, and for someone who has a lot of discharge or stool or mucus down below, they want to feel clean. So then there's that preparation time of having to have a shower, making sure the seton's okay, and that almost always takes away that spontaneity before engaging in sex. Some patients complain about bleeding and soreness, and feels like having or engaging in sex makes it worse. When I do speak to some patients, they say, oh, don't worry, me and my partner haven't had sex for 7 years, so we don't really need to talk about that. And that's avoidance in sex, and that's a problem in itself. And then often you can have certain operations or problems with childbirth that can affect the sphincters, and this can lead to the uncontrolled leakage of feces, which again can be very detrimental for the patient. And then the other spectrum is the psychological impairment, feeling very low. Some people feel that they have failed themselves, or disappointment because it's affecting how they interact with their partners, their children, their loved ones. There are a lot of women who are living in secrecy. Some people are embarrassed and no one's aware of this problem. They feel embarrassed in terms of going out, having to socialise with their friends, and it thus affects lots of relationships. So what are the causes of a rectovaginal fistula? So the commonest cause is really trauma from childbirth, and this accounts for 88% of rectovaginal fistulae. And it's particularly common in the other parts of the world, particularly in places like Africa. And these parts, you get young women who marry older men, and what happens is, because there's lack of resources, these women go into labour for 2 to 3 days. And what happens is you get the pressure of the fetus on the pelvis, and eventually these patients give birth to sometimes a dead fetus, and these women fistulate, and they fistulate really bad, going from bladder to vagina to rectum. And these patients get isolated from society. And really, no matter how small or big the fistula can be, it can still have a detrimental effect on the patient and on their quality of life. And then, of course, you have systemic problems such as Crohn's disease, and this is the second most common cause for rectovaginal fistula. And for those who have Crohn's disease, of those who have a fistula, 5% of them can be accounted for having a rectovaginal fistula. And then, of course, there is infection as well, such as a Bartholin cyst, and also complications from surgery. Nowadays, surgeons join bits of bowel using a stapled device, and sometimes you can catch the back wall of the vagina into the staple line, and again, this can cause problems resulting in a rectovaginal fistula. Various different types of cancers within the pelvis can result in a rectovaginal fistula, such as cervical cancer, or when the cancer is widespread. And also, lastly, radiotherapy is also a very common cause as well. And these symptoms of rectovaginal fistula following radiotherapy tend to be quite delayed, occurring in about 6 to 24 months' time. So what's the problem at the moment? Well, a rectovaginal fistula is very rare, and it certainly is an awful condition. They're very stubborn things, which is really challenging for the surgeon. And often surgeons may see them maybe once, twice, or 3 times a year in some local hospitals. There's not really true guidelines to help the surgeon to know what to do. And as a result of this, often patients have to go through lots of procedures before the fistula closes, and in some instances, the fistula tract may never heal. And along the way, and this is particularly what I'm more concerned about, is how treatment is affecting your social life, your work esteem, your work life, and sex along the way. It certainly is difficult to cure, and more importantly, we want to see how this affects you. We want to see it from your point of view. So then there's the question of a measure of success, and Phil will expand on the management of rectovaginal fistula, but as surgeons or physicians, we see perhaps level of success from reduced symptoms. So we might say, okay, when we first saw you, you had the problem of stool coming through the vagina, but now at the moment it's flatus, so I think we're doing pretty well. Or we may put you to sleep and have a look during an operation and see that the fistula tract is closed. Or perhaps it's because we can't see it on an MRI scan. And often with scans, the tracts are quite small, so they can be quite difficult to appear on MRI. And we may also think it's because we've avoided a stoma. So we think as surgeons, all these things have happened, that yes, we have got a successful treatment. However, from your point of view, we probably haven't. You probably think he's not listening, he or she is not listening to me or seeing things from my point of view. Yes, it's not shown on an MRI scan, but I'm still having problems with sexual interaction with my partner. I'm still having problems of feces still coming through my rectovaginal fistula. So this is an example of a consultation or an interaction between a doctor and a patient in clinic. So the doctor says, congratulations, your rectovaginal fistula is now so small that we can barely see it on examination and no longer discharges pus or stool. This means you've been successfully treated. And the patient says, I'm delighted to hear that, but I've had to move seats in my office to bring me closer to the toilet because I can only defer for 3 minutes. I still can't go out to parties or the theatre for fear of passing wind through the vagina, and I still can't have sex with my husband. Can we discuss what you mean by success? So what am I aiming to do over the course of the 3 years? So I'm really just looking through most of the literature out there on rectovaginal fistula and trying to understand what research has been done. And more importantly, I'm trying to understand how the condition affects you and how treatment affects you and your quality of life along the way. And one of the things that Phil and I are particularly interested in to see what the level of comfort and exposure of this condition is to junior surgeons. Because of course, if they're only seeing 1 or 2 cases throughout their training, and then when they become consultants, we want to know exactly how they feel in managing this condition. And the other thing is really to get rectovaginal fistulas to be at the forefront of the surgeon or the doctor's mind, to really have awareness of this condition. Just like there's a lot of emphasis placed on conditions like cancer, rectovaginal fistula is just as important as it affects your quality of life and it affects you along the way. So we want to raise awareness for surgeons, for GPs, district nurses, for nurses, to really get an understanding of how it affects you. Thank you.
Okay, so we're going to switch over to me now, and it's just going to take us a couple of seconds to do that. Thanks very much, Charlene. Well done. I've just tried to answer 1 or 2 questions as they popped up in the chat thread there, but I'm going to stop doing that now and concentrate on my presentation instead. Rebecca, is it? Oh, here we go. Rebecca, she's all over it like a rash. Oh my God. Can anybody hear me? Yes, yes. Okay, good. Right, sorry about that. So I'm just going to show you my screen now. Can I just have a WhatsApp message just to confirm that that can be seen from one of the guys? So I'm going to carry on talking about rectovaginal fistula, and I'll try not to duplicate anything that Charlene has just said. This is our fistula research unit, and there's a bunch of surgeons and gastroenterologists and radiologists and other people here. Some of them are quite famous names. The reason I show it to you is to try to show the interest that as a group at St Mark's we have in fistulas. We really are trying to get to grips with these things in some way, and these 3, Nusrat, Charlene and Lillian, are the 3 research fellows at the moment, and in the middle there Charlene, who you've just heard from, who is the vaginal fistula fellow. And then these 2, these are Janindra Warasavatani and Carolyn Vasey, and I'm going to mention them later on, that's why I'm showing you their picture. They've come up with a new technique for fistula repair, which is really a change in an old one, which I'm going to chat to you a little about. And I thought I'd just show you their faces since they're so important to rectovaginal fistula work at St Mark's. So I guess you guys know much more about the problem with rectovaginal fistula than I do, but I'm just going to focus your mind on that last line, and that is that this condition, one of the problems with it is that it's too rare to generate much expertise, both clinical expertise and academic research expertise. And I was very interested to see 2 or 3 people say almost exactly that in the chat threads just before I switched on my screen. And that rarity is a big problem for a number of reasons. And a really big reason is that it impedes research, and I'm going to explain a little bit why. First of all, there are lots of different causes for the rectovaginal fistula, and Charlene's just been through them, so I'm not going to labour this point, but this picture represents childbirth. It's probably better for everyone if I don't explain exactly how. And these are the fistulae that appear in Crohn's disease. This is a slide showing cryptoglandular sepsis, and this is a picture of a fistula arising from an anastomosis. This is actually a pouch vaginal anastomosis. And they're some of the big causes. But of course, if you've got an obstetric fistula versus a Crohn's fistula, the treatment for those two is different. And when something is so rare and you're trying to gather together as many fistulae as you can to understand them, when they're from different etiologies, the numbers that you have to focus on are even smaller. Here's another example of where rarity is a problem. It stops us being able to understand as well as we would like, for example, the influence of stomas. And there are always small numbers in the studies. Let me give you some examples. These are some of the studies which have been published from really big centres who do a lot of rectovaginal fistula work in the last 10 years or so. So at St Mark's we published a study in which we operated on 10 fistula per year. This big centre in Taiwan did the best. They got 17 per year. The Mayo Clinic you may well have heard of, one of the top 2 hospitals in the US, also doing a similar sort of work, 9 per year. A big tertiary centre in India, 1.5 per year. And in the US Practice Parameters publication, they looked at a number of units and they were looking at 3 patients per unit per year. So you can see that it's very difficult to generate real clinical expertise, but also to undertake studies in such small groups of patients. And the other thing that's a problem is the different operative techniques that there are, and that's because one size doesn't fit all in rectovaginal fistula surgery, in my view, and we do 4 or 5 different operations depending on the nature of the fistula and the patient and so on. And these are just some other examples of situations where you have different operations for different parts of the problem. So I'm just going to show you this slide very quickly. This is a paper that we produced in which we published this, and this was our algorithm for managing fistulas, and you can see 4 different operations at the bottom there, but actually some of these operations represent 2 or 3 different operations. So this is a Suave operation, an abdominal operation. I'm not going to go into detail about this because I don't think you'll find it terribly interesting, but I just want to demonstrate to you the range of things that we have to do for rectovaginal fistulas sometimes. This is an advancement flap I'm going to talk about at some points, and then we undertake perineal repairs directly, sometimes with a sphincter repair, sometimes with an omentoplasty, sometimes with a Marsh's flap, and then other people will use gracilis muscle and others. And again, I don't want you to get into the detail of all of this, but the point is that there are lots of different ways to operate on these fistulas depending on various anatomical features. And Charlene mentioned about success already, and one of the questions, or several questions that came up that were sent to us, included things like, can you tell me how likely a technique is to work? And the answer is that that's very difficult to answer. It varies between techniques, it varies between different causes of fistula, whether Crohn's or radiotherapy or whatever, and it varies from one centre to another. But in general, success rates are much less good than we would like, unfortunately. The abdominal operations seem to do quite well, taking down an anastomosis, a join in the bowel that we've made, perhaps because of a pouch or because of a cancer operation in the bowel, which has then led to a fistula into the vagina. Those can be some of the more effective operations when we operate through the belly and take that joint apart. But those are also very big operations, and the local repairs where we operate within the rectum or anus or vagina probably don't do quite so well, but sometimes those are the only operations that are suitable. And like Charlene said, there's 100 different ways we might decide whether or not a fistula repair has been successful. The absence of the fistula is what we would say as surgeons, but a patient might very reasonably want to maintain her continence, avoid a stoma, be able to go back to work and play sport and socialise and return to sex. And if we fix your fistula but destroy all those other things, you might very reasonably ask you if we have won on your behalf or not. That's one of the things we'll talk about in just a moment. And digging into sex a little bit more deeply now, as Charlene mentioned, fewer than half of patients return to intercourse in some studies of vaginal fistula repair. Fewer than half after we've operated on them, even if the operation is successful. And a quarter of those patients will have dyspareunia, which means pain during intercourse. And that's a real indictment, I think, about how we manage these things at the moment. That's something we really ought to try to change. Okay, Now I'm going to just put a few slides up to talk about some of the issues that arose in the questions that I was sent before the webinar, which I've written answers to, and which I think Gillian and Rebecca and Lindsay and the rest of the gang they'll put those answers in written form into the forum so that you get a slightly more detailed answer. But here are just a few things. One of the questions that gets asked a lot is whether or not there is genuinely a fistula and how easy it is to find them. And the answer is it can be hard to know. Now, sometimes a fistula is big enough for me to put my finger through. In that case, there is no question in anyone's mind. It's very obvious. But sometimes, and more commonly, fortunately, fistulas can be very small. And in that case, an MRI scan or an endoanal ultrasound just may not see them. It may look right through the fistula and tell us that it's not there. We don't believe imaging when it tells us that it's not there, although that is obviously a part of the jigsaw. Usually, when we take a patient to theatre and examine them under anaesthetic, usually we can tell. At that point, we can usually tell if there's a fistula or not. We've got a few different tricks that we use with various techniques with patients asleep to try and find them, and usually we can tell whether or not there is. And one of the questions mentioned, a lady said that she could tell that there was air, or she thought there was air coming through the vagina, and this was after an operation to lay open an anal fistula, and she was worried that that fistula had recurred, but this time into the vagina. And that is something that we have seen before, not recurrence into the vagina, but sometimes when you lay open a fistula at the front of the anus, so close to the vagina, and you lose some control of wind, which can always happen in response to laying open a fistula. Sometimes wind comes out of the anus without the patient meaning it to, and then because there's a deformity in the anal margin there at the front, that wind passes across the vulva and it feels like air is coming out of the vagina. And so sometimes when a woman tells me that she thinks she's got a fistula and I examine her really thoroughly in theatre and I can't find one, but I know that there is an internal anal sphincter defect at the front there, sometimes we think that's the reason why, and we will explain that. The next question is whether we should do an operation at all. And again, one or two of the questions that we had were from women who had very little in the way of symptoms and weren't sure what to do, or who had been advised by their surgeon that perhaps it might be reasonable not to do anything. The problem is this: any operation that we do to try and repair a fistula can do the opposite. It can make it bigger, and a bigger rectovaginal fistula is more symptomatic. In addition to that, the repair will very commonly, unfortunately, fail. So if we're going to embark on a fistula repair, which is reasonably likely to fail and might, if it does fail, make things worse, we have to ask up front whether or not that risk is worth taking. And if a woman says to me, I pass a bit of wind every now and then, apart from that I don't really have any trouble, there's a tiny bit of discharge occasionally, especially if I have diarrhea, then I will have a conversation with them about whether or not they really want an operation to fix that. Because there's a very real possibility that I'll make their life worse, not better. On the other hand, if the symptoms are pretty bad, recurrent infections are occurring, there's a lot of discharge, sometimes perhaps stool, or a lot of wind passing out through the vagina, then a woman might well say to me, look Phil, things can't get an awful lot worse than they are, I really want you to repair my fistula. That balance is the crucial thing, and in my view that balance really sits in the lap of the patient rather than the surgeon. For some women the idea that a fistula is present, regardless of how many symptoms there are, is abhorrent, and she wants me to do an operation regardless, and if she understands the risks that I might make things worse, then of course I will oblige her in that regard, whereas other women have pretty remarkable symptoms but don't want surgery, don't want things to get any worse, and try to settle with the status quo. And that very much, as I say, is in my view a patient-driven question. There were a lot of questions about setons. Most rectovaginal fistulas are not long. Most of them are much more like a buttonhole. There might be 0.5 centimetre of tissue between the anorectal opening and the vaginal opening of the fistula. Now the idea of a seton in an anal fistula, which might be 2, 3, 4 or more centimetres long, is that from time to time the skin will close over the fistula and then pus will build up behind, developing into an abscess which will then burst. With an established rectovaginal fistula, that happens very infrequently. There are sometimes long anal fistulae that end in the vagina, but that's pretty unusual. Mostly they are short, often epithelialized fistulae. And that kind of fistula does not need a seton in it. Not only are they unnecessary, but sometimes they can actually cut into the fistula and make the hole bigger. And very commonly, the first thing I do when I meet a woman who's been sent to me with a rectovaginal fistula with a seton in is tell her that I think it should come out. And she may well let me remove it right there and then in clinic, or she may want to think about it for a while before we remove it. And I'm happy, of course, with either of those. But very commonly, I take them out because they are not necessary, in my view. Abscesses being incredibly uncommon in this setting. So in general, rather than talking about how to get clean with a seton in situ or whether or not it's okay to have sex with a seton in situ, in general, I just take the seton out. And that's usually a perfectly safe thing to do. There are lots of questions about what people can do and achieve with a fistula in place. What kind of sports can they play? Well, again, once the fistula is established, once it's been around for a while and it's mature, it's often epithelialized. Actually, probably pretty much anything is okay, but of course if you do something which is uncomfortable, you'll probably want to avoid it. And people always think about things like cycling and horse riding. I can tell you that I've got more than one patient who undertake those activities. I've got one patient with a fistula into her vagina who's a professional horsewoman, and she gets on okay. It's tough, of course, but she gets on okay and is able to continue with her job. So I think, broadly speaking, most sports are okay. Now, that's not the same straight after a repair when you want everything to be able to settle down and have a chance to heal. And it's not okay right at the beginning when the fistula appears. But once the fistula is established, and I'm talking about a few months down the line and a few months away from a repair, I think you can be guided pretty much by your symptoms fairly safely. And actually the same is true of sex. I think setons cause more of a problem with sex than the fistula themselves, and with a mature fistula it's probably okay. I always say to people that they should be kind of sensible and think about positions, and obviously you don't want any direct pressure to be put on the fistula, and some positions produce direct pressure in different parts of the vagina, and so it's obviously sensible to be careful and to start off gently and slowly. But broadly speaking, I think sex is fine most of the time for most patients. Obviously take care and be sensible and see how things go. And the other question is about delivery and whether or not women can undergo vaginal delivery. The answer, of course, is that you can have a vaginal delivery if you want. I tend to advise caesarean section, and that's for a couple of different reasons. First of all, if you've got a fistula already, then that whole sphincter complex is weakened. And unfortunately, as many of you will know already, tears running from the vagina backwards down into the anus or towards the anus and rectum are all too common in vaginal delivery, particularly with a first baby for one reason or another. That's often the cause of a fistula, but even if it isn't, once a fistula is there, there's a weakness within the tissues, and I think that probably means that a further tear is both more likely and more likely to be serious. There is some evidence to support that, particularly in Crohn's disease, but also in non-Crohn's fistulae, both anal fistulae that occur at the front of the anal canal, but also with vaginal fistulae. And the same is true after repair. The whole area is weakened at that point. And any repair that we've made, even if it's been successful, will leave a weaker set of tissues at the front there. And so, again, a tear is both more likely and more likely to be serious, I suspect. And so I would tend to advise patients to have a caesarean section with a rectovaginal fistula past or present. And in my experience, most patients want it, and most obstetricians are quite happy to provide it, although women do sometimes worry about that, and midwives can sometimes take a slightly different view. But your surgeon will be happy to support you with a letter to describe why it's important. There were a few questions about how to care for a fistula after repair has taken place. And I'm afraid there's very little science here. It's all kind of voodoo, and if you ask 10 different surgeons, they'll give you 10 different ideas. My own set of advice is that patients should limit anything which is going to put a stress on the area. And certainly that would be for the first 2 or 3 weeks. I'd be quite anxious about someone doing aggressive Pilates and yoga, if that's not an oxymoron. But, you know, stretching the area, doing squats and lunges, these kinds of things which are likely to put some tension on any repair that we've made. And I tend to keep patients in hospital for 2 or 3 days after I've done a flap repair or another type of repair, encouraging them to stay in bed for the first day or two. They can get up and potter around, but not to do too much, because I want the repair to stick and to stay in place. I encourage them to go on a liquid diet for the first 2 or 3 days so that they hopefully don't pass any stool, but then to use laxatives so that when they do, that stool is soft and isn't a big traumatic experience. We often give antibiotics. We use bowel preparation beforehand to make the bowel empty, and of course if they've got a stoma, then a lot of these worries just aren't there. There were a number of questions about how to know whether or not a repair has been effective, and the answer is, unfortunately, that you can't really easily know if a repair has worked until you know that it's failed. What that means is that we tend to watch and watch and watch and try not to rush any decision about these things. I will suggest to women that we wait several months, hopefully 6 months, before we start to whisper the words that it might have been successful. And I wouldn't report success clinically or in a trial until the patient had been symptom-free for at least a year, and I had a scan and an examination under anaesthetic to prove that there was no fistula. Someone mentioned in the chat thread earlier that even if the fistula repair hasn't been successful, that they might have a reduction in their symptoms, so that it's gone from stool and lots of trouble to now just a little bit of wind every now and again. And in that setting, if the patient is happy, or at least happy-ish, and happy with the decision, then I might well suggest that we take things no further for the reasons we discussed earlier, because there's a real risk that I make them worse again. And another thing that people wonder about is whether there's some kind of salvage procedure that they can have. You know, they're 3 weeks out or 6 weeks out from their repair, and things are just starting to go a bit wrong. There's a bit of wind maybe they've had a bit of pain, and they're worried now that their fistula might be recurring, and they want to know whether there's something we can do at that point to rescue the situation. And the answer, I'm afraid, is that there is not anything that you can do at that point. You simply have to wait. Either it will fail or it won't. If it does fail, it won't be anything that you have done. And if it does fail, then we should wait a good long time for everything to settle right down before we try and undertake a further repair. And that time might be 6 months or a year, and it's really frustrating for patients. And I really do understand that, and I'm sorry for it. But if we operate early in an inflamed area, it will fail again. And there are a limited number of times you can do these things for various reasons before it becomes impossible to try again. So we have to save our attempts and make them as good as they can be. I've just had a question about whether or not people should get in the bath post-repair. In general, having these wounds wet for a prolonged period is not a good idea until the wounds have settled right down and the skin has sealed. And that will usually be several weeks in, so I wouldn't advise a bath. I think it's very reasonable to have a shower from the top down and wash things off and then pat them dry with a soft, fluffy towel. But I wouldn't sit in a bath 2 or 3 weeks out from an advancement flap or a Marsh's flap type repair, because it would make me very anxious that the whole thing was going to get wet and macerated and soft, too soft. Having said that, a few weeks later, once everything is sealed, then I'm much less anxious about it, and at that point I'd be much more comfortable. Again, I don't have any evidence to support what I've just said, and different people will say different things, but that is the advice I have. And stomas, a lot of the questions were about whether or not stomas are useful, and here are my thoughts on stomas. We don't know if they really help. There isn't evidence to support it, but we all, as surgeons, almost all, believe that they probably do help. And if you come to me and you've had 2 attempts at repair elsewhere and both of them has failed, I will tell you that there's probably not much value trying again without changing something, and that something might well be a stoma. Now, women will often not accept a stoma first time round, but if I said to you that I thought your best chance was the first chance and your best chance was with a stoma, you might take a different view. Certainly not everybody does. And really, the centre of that is these two key questions at the bottom. First of all, have we given the fistula the best chance we can to heal, whichever repair it is, whether it's the first or the third or the sixth? Have we given it its best chance to heal or not? Will we all feel at some point, at the end of all of this, that even if we haven't got it to heal, we put everything into it, we held nothing back, and that means making a stoma? On the other hand, we must ask the question, what do we do if I fail to repair your fistula and now you've got a stoma? Your symptoms will be better from the point of view of the fistula, even if it persists and doesn't heal, but you'll have a stoma. And again, if your fistula symptoms are not too bad, then having a stoma might be worse out of those two things. So again, it's a reason to step back from repair in some patients in whom the symptoms are not too bad. If you do have a stoma and we fail to repair your fistula, then the choices will be to reverse the stoma and have the fistula symptoms back, or keep the stoma and avoid the fistula symptoms. And that can be a very, very difficult decision for a woman to make. Really, really difficult. And as a result of that, it is, in my view, something that should be considered before we do the operation to fix the fistula under a cover of a stoma. And it may be that the woman says, actually, I'd rather stick as I am, and that's okay. Okay, let's dig into some of the other questions. And Charlene, if you want to chip in at any point, then just lean forwards and tell me to shut up. I'm going to stop sharing my screen. Here, whichever one of us out of, you'll see, whichever one out of Charlene and I is speaking the most. Charlene, do you want to answer a couple of questions that you've seen pop up so I can have a sip of my tea? Charlene, can you hear me? Okay, can everyone else hear me? Can everyone else hear me? Yes, okay. Well, while Charlene sorts out whatever the issue is with her sound, let me dig into another couple of questions then. I'm going to go from the bottom up. Why does fibrin glue not work? It's a good question. Broadly speaking, fibrin glue doesn't work because it comes out. It just leaks out of the patient. It doesn't fill the space for very long. It's been mostly tried in anal fistulas. It's even less likely to work in rectovaginal fistulas because they're so short. There just isn't space to put the glue in. And when we think of glue, what we think of is two surfaces which you can then stick together with glue in between. But that's not what a rectovaginal fistula is like. It is like a buttonhole. And what you do with glue or a plug is to try and fill that hole. It's not a good way to try to repair a fistula, a rectovaginal fistula, and it's never been shown to have a high success rate in any large-scale or reasonable study. And the repairs that we all do involve creating a space between the anorectum and the vagina and then filling that space with a big chunk of tissue, or else advancing part of the rectum or vagina to cover the hole in one way or another. So glue is not how I would go. Charlene, can you hear us now, and do you want to chip in? No, she still can't hear me. So I'm going to carry on. I promise that I'm not doing this deliberately because I like the sound of my own voice. Who should perform repairs, colorectal or urogynecology? I think the answer is whoever does it well. And traditionally it's been colorectal surgeons in the UK. It is sometimes gynecologists in other countries. There are arguments for both, but frankly I don't think it matters. But whoever's doing it well, doing it frequently, and whoever can do all the different techniques which are useful. So in my view, it should not be that a surgeon does one thing and they reproduce that one thing for all of their patients, but they tailor their operation according to the nature of the fistula. And that means having an armamentarium of available operations that they can offer. They also need to have experience so that they know when to advise patients that a repair probably isn't the right way to go. How does colorectal surgeon know how to operate transvaginally for rectovaginal fistula? Well, the vagina is a fairly easy access point for a repair. It's much more difficult to operate in the anorectum. So in general, that isn't a problem. But also vaginal repair from the vaginal side is not the choice that most colorectal surgeons would go for, because the problem is generally arising from the other side. And so we tend to take the view that we should be fixing it either from the rectal side or from within the space, the rectovaginal septal space, the space between the anorectum and the vagina. Charlene? Can you hear me? No, still can't hear me. Okay, I'm sorry. If the symptoms are mild, does the fistula need a seat on so the fistula does not branch? No. In general, they don't, for the reasons I explained earlier. Because it's a small hole, in general, you don't need to place a seat on, and the fistula won't branch, in general. Now, if you've got Crohn's disease or radiotherapy injury, then they do misbehave more aggressively. But once the fistula is established, that isn't likely to be the case, because it can drain very effectively. Is vulvodynia linked to RVF? Oh, are you in, Charlene?
Yeah. I thought that was an interesting question about vulvodynia. I don't think they really know the true cause for vulvodynia, and of course that is pain and irritation across the vulva, and it could be probably from the fistula if you had a rectovaginal fistula first, because I note that the person in the question said that they have both. So yes, of course, having a rectovaginal fistula, if you have consistent discharge and mucus, that can cause irritation to the vulva or the labia or the opening of the vagina, which can be linked. But I haven't read in the literature that there is a true link between them, but I think having the fistula in the first place can be a secondary cause for that.
Yeah, and it can be the fistula, and also, of course, the operation. One of the operations that we do is a Marsh's flap, and that involves opening the labia majora, making a cut down it vertically, opening the tissues and accessing a fat pad inside called the labial fat pad, which we can mobilize, lift up and swing down and place into the rectovaginal septum. And that's quite a nice way to put a chunk of healthy tissue in between the two sides of the fistula. And I say it's nice from my point of view because it's quite easy to access. It's quite a small bit of tissue, but it's often enough. It's not always nice for the patient, and sometimes we have patients whose fistula heals, but they then have pain or numbness in the vulva as a result of the Marsh's flap repair. And of course, that once again, they're making a trade-off between one thing and another. And that's one of the reasons for the omental flap repair. And I promised earlier that I'd mention Carolyn Vasey and Janindra Warasavatani, and they have started to access omentum, which is the fatty tissue that we all have sitting inside our abdomens, and bringing that down to put it in the space where we place a Marsh's flap or a gracilis flap. And it may well be that that technique is less morbid, by which I mean it doesn't cause the symptoms in the vulva or in the leg that you get from those other sites of donor tissue. That's one of the techniques that we're using at St Mark's now in patients for whom it's suitable. We need, of course, more numbers to demonstrate whether or not it's a highly successful technique, but it's quite a nice new technique to add to the armamentarium. In some patients it's not suitable, but in others it's exactly the right thing, and you can get quite a big wad of tissue. Yes, the answer is that technique is being performed at St Mark's. It's gone through a kind of initial stage of being looked at, and we've the results of that are being published shortly, and we're using it now routinely in patients where it's the correct technique. But I'm not trying to sell it as a magical new cure-all technique. It's just another It's just another trick, another technique that we have. And rather than thinking about which one is better, which is what people always ask, which is the best one, which one is going to work, that's not really the right question. The right question is which one is the one which, in me, is most likely to be effective. And it varies from one patient to another. And not just which one is most effective, but which one am I willing to put up with the downsides of. So, for example, that technique, the omentoplasty technique, patients always have a stoma with it. So it may not be the right first choice for a patient, where you might prefer an advancement flap where we don't necessarily want to place a stoma. So there are different reasons why we might choose one over another. Okay, Charlene?
Yeah, Phil, did you answer the question? Sorry, because I lost you there. Is the low numbers, because we mentioned how it's quite rare in our presentation, is the low numbers because we don't know, or is it because there aren't many of us? So the difficulty with that question is we don't really know the true number of patients who are affected with rectovaginal fistula across the country, and one, that could be because of many things. Some patients are living with it in secrecy, some patients may not present with it to their GP or to the hospital, and there is no true registry or way of monitoring this, and this is particularly one of the things that I'm looking into with my research, is to sort of delve into the numbers of rectovaginal fistulae over the years in the country.
But in addition to that, it is a pretty unusual condition. There aren't very many patients, and so, you know, in a normal district general hospital, there might be 1 or 2 women a year who present for a rectovaginal fistula repair, and so you can see the sorts of small numbers that we're talking about over the country. Okay.
Did you see the question if the symptoms? Oh, sorry. Yeah.
No, you go ahead, Charlene.
If the symptoms are mild, does that mean the fistula needs a seton or surgery? Did you see that question?
Yeah, I mentioned about, and I've answered.
You've answered that. Okay, great.
And someone else said, just got home from having my seton removed. Should I watch and wait? There it is. Just returned home. Seton removed. Is watch and wait an option? What do you think, Charlene?
So, if the setons if it's been removed, the tracts for rectovaginal fistulas tend to be very short, and the literature does state that it's not always the right thing to put a seton in a rectovaginal fistula, because often these, because the tracts are very small, the setons fall out. And sometimes in clinic we'll see patients who have had setons in for a long time, and we take them out and they actually feel a lot better. So in that way, sometimes it could be a watch and wait thing to see how things go, to see if your symptoms improve, and they do behave quite differently from other types of perianal fistulae, in that when you put a seton in, it often is to encourage discharge or to prevent that flare-up of abscesses, and you don't really, that doesn't happen with rectovaginal fistulae because the tracts are very short.
And once the seton's out, watch and wait is very reasonable, because you'll get a sense of what your symptoms are like without the seton, and whether or not you need to go on to have something else done will depend partly on that. If your question is it likely that my fistula is going to heal once the seton has come out, I think the answer to that in general is that it is unlikely. But it does give you an opportunity to see what life is like without a seton with your fistula, and to then take a view on whether or not it is worth thinking about going on to have an attempt at repair, bearing in mind the pros and cons of all of that, like I mentioned earlier. Okay, I've got 1 or 2 other questions which I didn't get through that were from the ones that were sent in beforehand. I think I've answered most of them. There are a couple of questions about pouches, rectovaginal fistulas, or pouch vaginal fistulas in this case. Even more unusual, just because there are fewer people with pouches in the world, but actually within that group it's not as uncommon as we would like to get a fistula, and sometimes to get a fistula to the vagina, and they can sometimes happen a while down the line, and those are very challenging to treat. Pouch fistulas are a whole conversation in themselves, but it depends where the fistula is, whether it's at the join of the pouch, what we call the anastomosis, or whether it's further down below that, whether there's Crohn's disease there and so on. But those can be very challenging to meet with a pretty poor success rate for repair, although there are things that we can try. It's often necessary ultimately to make a stoma in that setting, depending on the level of symptoms, of course, if the patient has. If they're not too bad, that's okay. But if the symptoms are poor, it can often be necessary with a pouch fistula to defunction the pouch to make a stoma in order to just make the symptoms livable with. Okay.
Phil, I've got a question as well. Yeah, so I've got a question. Are there any official guidelines? Are there any official guidelines as to what success looks like, or any future trials or research in the area that we can look into? And that's a great question. And this is exactly what I'm trying to target and hit the nail on the head during my research over the next 3 years. And more importantly with that question is really involving patients who are affected by a rectovaginal fistula. And as I alluded to before in my presentation, that often we look at things objectively by looking at scans, but the surgeon's looking through on the fistula during an operation. But we are trying to develop an assessment tool or a quality of life tool to really determine what shows a successful treatment. And the way that we'll be doing this is involving you along this way of involving patients with our research, and we'll do this by means of doing qualitative interviews. So these are unstructured interviews or a conversation to tell me what is life like with a rectovaginal fistula, how does the treatment that us as surgeons do affect your quality of life along the way. And we'll do this to many, many patients, and hopefully with a panel of experts really home in onto an assessment tool, and we'll use that to help us to determine what success is. And I think that's a great question, and it's certainly something that is required for something that is so rare, and to really see it from the patient's perspective. So I definitely will be doing that over the next few years. And whether there are guidelines, yes, there are papers there that sort of postulate or suggest what things should be done, but there are no definitive guidelines as to say what should be done exactly. And because it's so rare, it's difficult to have trials or research into this field. So often when surgeons see a patient with a rectovaginal fistula, they will do what they think is best. And when they become more and more problematic, they may be referred on. But this is certainly a big problem or hole within this area of rectovaginal fistula that I will be targeting on, for us to really understand what success means to us and to you as well.
So the idea, developing the core outcome set and the quality of life questionnaire that Charlene is doing, is that we can try to make sure that when studies look at repair for these things in the future, they do so with patients in mind, and they answer the question really effectively for patients, rather than just in the way that we find easy. You know, the objective measure is fistula, yes or no. That kind of binary answer is probably of very little value to most patients. Okay, there's one or two other questions that I'm going to dip into now. Can RVF form from a branching anal fistula? The answer is yes. If your anal fistula is well controlled, often with a seat on, then it shouldn't happen, but it absolutely can, unfortunately. It's an unusual complication of an anal fistula, and it's a good reason for trying to get an anal fistula under control as fast as possible, get a seat on in, and try to avoid a big abscess appearing in the rectovaginal septal space. A couple of other questions which I haven't really addressed from the list I was sent beforehand. There was one question about smoking and a high BMI. So smoking and being overweight are both negative risk factors for a fistula repair of any kind, but particularly rectovaginal fistulas, being successful. So if you want to give it the best chance to repair, as a surgeon you will always ask your patients to stop smoking and lose weight as much as they can before you undertake a repair. And what I said earlier about trying to make sure each chance that you have, each repair that you have, is the best chance that it can be, that's obviously a a good set of things that you can aim for. And someone else talked about flaps, lift and fixation. I'm always really impressed when people talk about new techniques that I've just about heard of and the patient has heard of it as well. I'm always really impressed. Flaps are good treatments for rectovaginal fistulas in many ways. They have their disadvantages, but it's a pretty robust technique that we've used for a long time. The lift procedure has been used less frequently for rectovaginal fistula, and I think it has to be a very carefully selected fistula. It has to be low down, so it has to be coming across the sphincter complex. And we've used the phrase rectovaginal fistula all the way through this, but what we mean by that is any fistula between the anus or rectum and the vagina. And so sometimes they're low and they go through the sphincter complex, and in that setting it might be reasonable to do a lift. If they're higher at the top of the sphincter complex or above it, then the lift is not suitable. And fixation is a way to excise a fistula in completely. And that is not something that I would personally use within a rectovaginal fistula setting. I think I can do a more precise job with a diathermy or a knife myself, and it worries me that it will make a bigger hole than is necessary. But it's a brand new technique, so who knows? Okay, let's look at some of these. Even though mine is healed, J-pouch RVF surgically corrected. That's great, well done, whichever that surgeon was and you, fantastic. The idea, okay, so, that was just a compliment. Thanks very much. I should have read that before I started reading it out. Is there a patient-reported outcome metric for perianal fistulas? Aha, good question. So there is one for Crohn's perianal fistulas. Charlene is doing one for vaginal fistulas. Nusrat, whose picture I showed you earlier, Nusrat, is doing one for non-Crohn's anal fistulas, and Lillian is doing one for pouch fistulas. So the idea is that by the time these guys have been through, we'll have a proper patient-reported outcome measure in all of those areas of fistula, and also a core outcome set, so that anyone doing research in the future has a better baseline to start from. Charlene, have you spotted any more?
No, that's it for me. I've just got compliments that people are really great. No, yeah, sorry, go ahead, Phil.
Okay, so in that case, so I'm just going to mention one or two more things, because I think they're the things which have pinged up quite a lot. The question of cetons is one, and someone in one of the questions talked about sex with a ceton in place, and she said sometimes the ceton snags, and she's even had some bleeding because of that. That is a problem, I think. That means that the fistula is at risk of getting bigger, and that would be a very good reason, in my view, to take that ceton out. And that's I think, quite a valuable take-home message. It's something to discuss with your surgeon and ask them if they feel the ceton remains necessary, or whether it's a nice, short, mature fistula, and taking the ceton out might be a reasonable thing to do. And as I say, in my experience, it very commonly is the right thing to do. Not always. You occasionally get long fistulas into the vagina where it's worthwhile keeping a ceton, but usually that is not the case in my experience. And the other questions are the ones about stomas. And I don't want to labour that point particularly, but I think it is a really important and interesting question which we haven't got to grips with as surgeons, and I think patients, in my experience, really struggle with this. Partly, of course, because we don't know what the right advice is, clearly, but if a surgeon is discussing a stoma with you, that is a conversation that it's worth getting into. It doesn't mean that you have to have a stoma, but I think it is a conversation that it's worth having, to think about the pros and cons of making a stoma, and in particular those two questions that I mentioned. Whether we're doing everything we can to try and get the fistula to heal, and what we'll do if the fistula doesn't get closed. So that's something I think it's worth discussing. I'm sure that you guys all discuss this with each other on the chat thread the whole time. Okay, here's another question. I had an RV fistula fixed but still have a sinus with no internal opening. So I assume that's a vaginal sinus, I guess. The answer is that a sinus on its own like that probably won't heal on its own, but it also may well be not causing too many symptoms. You know, if there's no opening into the anus at this point, then there shouldn't be any wind coming through, and it should be that there is a relatively low risk of getting infections within the vagina. So I would hope that with a sinus, symptoms are relatively modest, and that might well mean that it's one of those situations where intervening is more likely to make things worse than better. Thank you, Tanya, for that message. It may well be that that we do make contact with you, not just you personally, but anyone in the group who's interested in taking part in these bits.
Yeah, thank you very much.
Charlene, would you mind just typing the email address into the message bar there, just so that people have got one last look at it?
Yeah, sure.
And if anyone wants to make contact with us for clinical advice, I'm really sorry, but we can't offer clinical advice about your own situation, because, you know, we need imaging, we need to assess you and examine you and all those other things. But if there's any further feedback that you want to offer, any kinds of things that you think we ought to be thinking about within the fistula research unit with regards to rectovaginal fistula, that's the kind of thing we're really, really keen to hear about. So please do make contact with us if you want to. Charlene, have you got that email address in the message bar?
Yeah, just getting it now.
Oh, great, thank you. Sorry, didn't mean to. Gillian, are you going to come back on and close up?
Hi everyone. Hopefully you can see me. Can you see me? Hopefully. Just wanted to say a massive thank you to both Phil and Charlene for giving up their time on a Sunday evening. I think we can all agree that has been really fantastic and very informative. And again, just to emphasise, I know this is obviously a population group in the wider fistula support groups that have asked for this specifically to be focused on for a long time, and I know we've kept you waiting to get it happening. So it's been really, I think you can see even from the feedback that people with rectovaginal fistula, you know, there's not a lot of advice out there. So this has been hugely invaluable. So really a massive thank you to both of you just for sharing your expertise. And I see there that the email has come up in the chat bar. To everybody who's been participating, thank you for joining us. Obviously it wouldn't happen without you guys coming. And do feel free to keep posting messages and feedback. I know that these guys from St Mark's love to hear how it impacted you guys, just hearing from them. So yes, do obviously use the email to get in touch, but do recall what Phil and Charlene said, that they obviously cannot offer clinical advice or speak about your individual case. That's really, really important. So we're very, very fortunate to have access to these guys. So if you just could refrain from asking clinical questions, that would be fantastic. And I don't really have anything else to say, so we're gonna close the webinar now. Do stay tuned for more information, and when we hear anything more about even looking for recruitment for these studies, we will post that in the group. So do keep your eyes peeled and keep in touch. And obviously Rebecca has recorded this, so it should be available to watch, and also for people who couldn't make it because of time zones or other conflicting commitments, this will be available. So we will post that as soon as we have it. And so that's us for tonight. Thank you so much to everyone, especially Phil and Charlene, and also the rest of the team, Rebecca, who is the tech wizard behind all of this, and Lindsay as well. Really, really appreciate everyone's help. So I'm gonna sign off now, and we will stop the recording soon. So thank you very much, and good night.